I'll be discussing some of my PhD work related to promoting the differentiation of neural progenitor cells into oligodendrocytes through the induction of OLIG2 expression. So as we all know, spinal cord injury is accompanied by a complex pathophysiology with many different consequences, one of which is oligodendrocyte loss, and that is accompanied by demyelination. Now, oligodendrocytes are the myelinating cells of the central nervous system that facilitate efficient signal transduction. And so replacing these damaged oligodendrocytes with healthy new oligodendrocytes is an important therapeutic target in order to promote functional recovery. Now, one way that we can do this is to transplant neural progenitor cells, which are cells that can self-renew as well as differentiate into neurons, oligodendrocytes, as well as astrocytes. However, in practice, when we transplant these neural progenitor cells into areas of spinal cord injury, they tend to differentiate into astrocytes at the expense of both oligodendrocytes and neurons. And so in our lab, what we aimed to do was to bias neural progenitor cells in order to give rise to a greater proportion of oligodendrocytes. And so we developed these cells known as oligodendrogenically biased neural progenitor cells that are aimed to give rise to a greater proportion of oligodendrocytes while still maintaining tripotency, meaning they can still give rise to both neurons and astrocytes. So what we did to generate these cells is we introduced the OLIG2 transcription factor into neural progenitor cells under the control of the doxycycline-inducible promoter. And so from now on in my presentation, I'll be referring to them as IONPCs. Okay, so here, can everyone see my arrow? Yes, perfect. So here on the left-hand side, we have images of the cells following 0, 3, 7, and 10 days of doxycycline treatment. And then on the right-hand side, we have a heat map showing the transcriptional changes at the same time points. And so what we found is that the IONPCs display progressive oligodendroglial lineage development following doxycycline administration. And so what I mean by that is that with longer doxycycline treatment protocols, the cells tend to express more oligodendroglial lineage genes. And so by 7 days of doxycycline treatment, these cells expressed robust expression of oligodendroglial lineage genes such as APC, OLIG1, OLIG2, and PDGF. So next, we aim to assess the differentiation capacity of the cells in vitro. And so we differentiated IONPCs as well as NPCs as a control and stained for beta-3-tubulin, a neuronal marker, GFAP, an astrocyte marker, Nestin, a progenitor marker, as well as O1, which is an oligodendrocyte marker. And here we have the quantification results. And as you can see in this pink or reddish color here, we did in fact find that the IONPC group gave rise to a greater proportion of O1 positive oligodendrocytes compared to the NPC control group. Now we aim to assess the cells further using RNA sequencing. So we performed RNA sequencing on NPCs as well as the IONPCs, and this further corroborated our results from the past 2 studies. Over here, we have all the differentially expressed genes between the 2 cell types. On the left-hand side in the reddish orangish colors down here, we have the genes that are upregulated in the IONPCs versus those that are upregulated in the NPCs up here. And then here on the right-hand side, we have some selected genes that we chose to look at. And this basically confirmed the results from the previous experiments with IONPCs being enriched in genes such as OLIG2, PDGF, OLIG1, MERF, and so on. Okay, so we next aim to use cell atlases from published single-cell RNA sequencing databases in order to assess whether any certain identity of cells is upregulated or downregulated in our IONPC and our NPC RNA sequencing data. And so here what we found was that the IONPCs exhibit enrichment in gene expression signatures of distinct cells along the oligo lineage. So in other words, here in the IONPC group, we found enrichment in gene signatures that correspond to myelin-forming oligodendrocytes, newly forming oligodendrocytes, committed oligodendrocyte precursors as well as mature oligodendrocytes here. Whereas on the other hand, in the NPC control group, we found that those cells displayed signatures that more closely resembled excitatory interneurons, inhibitory interneurons in more neuronal populations. So we next aim to assess these cells in vivo. And so we transplanted them into rats that had a spinal cord injury 2 weeks following injury. And then at week 15, we sacrificed the animals and performed histological assessments. So here we stain for APC, which is an oligodendrocyte marker, GFAP, which is an astrocyte marker, as well as beta-3 tubulin and NEU1, which are neuronal markers, in order to assess the in vivo differentiation capacity of the cells. And in order to identify the transplant-derived cells, we stained for STEM121. And here we did find that the IOMPC-derived cells did successfully give rise to APC-positive oligodendrocytes with a high efficiency. And then finally, we aim to assess the myelination capacity of the cells. So on the left-hand side, we can see that the STEM121 is co-localizing with MBP, so myelin basic protein, which is a marker of myelin. And this is surrounding the NF200 endogenous axon. So this is suggesting that remyelination is occurring. And then we also performed immune electron microscopy. And wherever you see these white arrows and those black dots are signifying any of the transplanted cells. And because these transplanted cells are in close proximity to this thin structure here, and this one here, that's suggesting that remyelination is occurring. So with that, I would like to thank Dr. Michael Failings, as well as Dr. Mamad Kazai and Dr. James Hong, as well as past lab members, Dr. Kazuya Yokota and Dr. Nader Hirati, and finally our collaborator, Dr. Shimshuki Shibata.
Thanks very much. Great presentation. Any questions? Questions? I have one. So what's next? What's the next step for your research?
That's a great question. So here we use the OLIG2 transcription factor. And the idea here is that different timelines of doxycycline. So here I showed following the cells after 0 days, 3 days, and 7 days, and 10 days of doxycycline treatment. So the next steps are to basically identify what the optimal dosage of doxycycline is and to move forward from there.
And what is the duration? How long does this myelin last, this new myelin for? Does it have a lifespan? And is it clinically important?
That's a good question. So we did, the assessments that we did over here in vivo were at 15 weeks following injury. However, so far we haven't looked after that. So that's a good question to look for in the future.
Any other questions? Great. Well, let's give her a big, also got a question? So, Carrie, sorry.
I was just gonna say, is dose the only thing that you want to look at, or are there multiple factors that you want to look, like duration, timing?
Oh, absolutely. There's definitely a lot more that we're going to look at. For example, the thickness of the myelin, the rate of myelination. So how many axons are actually being remyelinated? There's definitely a lot more that we'll be looking at. Yeah.
Thank you.
Thank you very much, Catherine. Very great. Great presentation. Yeah. Our next presenter will be Nayab Panjani, and he will be discussing his research project on subcommissural organ-derived peptide promotes functional recovery and enhances tissue repair in rat cervical spinal cord injury model. Okay, there you go.
Remove this music. What is it? Yeah, I think you heard this one. Okay, so I'll help you with that. This one, right? This one? Okay.
Okay, so thank you to the organizers all for giving me the opportunity to present my research. And so my name is Naya Punjani. I'm currently a PhD student in Dr. Michael Failings' lab. And so I'll first start off briefly by going through the pathophysiology of spinal cord injury, which I know everyone here is probably quite familiar with, but I'll just do a brief overview. So following the primary injury that occurs as a result of traumatic spinal cord injury, we have the initiation of various secondary injury cascades. In the early phase of spinal cord injury, or the acute phase, we have the start of the inflammatory response, as well as hemorrhage, demyelination, and cytotoxic ionic release. As we proceed into the subacute phase of spinal cord injury, we have the activation of reactive astrocytes and the start of proteoglycan deposition. And as we proceed finally to the intermediate and chronic phases of spinal cord injury, we have the formation of an inhibitory perilesional scar. So that paired with the pro-inflammatory environment following spinal cord injury impairs neural regeneration, and as well as the functioning of glial cells, overall creating an environment that impairs patient recovery. And so we need to be able to target multiple aspects of these secondary cascades while also enhancing endogenous neural regeneration and recovery. And so my project employs the use of a small peptide drug, which is derived from the subcommissural organ spondin protein. So the SCO spondin protein is present during human neurodevelopment and has been shown to be involved in neuronal survival, differentiation, and proliferation, and proposed to be involved in vertebrate spinal cord regeneration. So I specifically test a segment of this peptide, so a 12 amino acid peptide termed NX or NX210C. So I'll be using that moving forward, and it is derived from thrombospondin type 1 repeat sequences. Thrombospondin specifically have been shown to be involved in axon pathfinding, as well as cell-cell and cell matrix interactions, and NX has been tested to be safe in healthy volunteers. And so the purpose of my project is to test the efficacy of the NX peptide to promote repair, as well as functional recovery in a rat model of cervical traumatic spinal cord injury at 2 therapeutic time windows. So I'll go into that in a minute. And so we're going to look at functional recovery, so motor function, as well as looking at the tissue and cellular anatomical changes. And so in terms of my study model, so we use female rats and we do a clip compression contusion injury using a modified aneurysm clip at the C6, C7 level of the spine. So that is to mimic compression contusion injuries that occur in cervical level traumatic spinal cord injuries. And then we administer this either starting 4 hours or 8 hours post-injury, so corresponding to about 12 hours and 24 hours in humans. And so following that initial injection, we have daily administration of the peptide, followed by forelimb and high limb locomotor measures, as well as other factors that might be important clinically, such as weight gain and bladder function. And then we analyze those results. And so in terms of our results, at the 4-hour time point, we did see significant improvements in grip strength, so forelimb function, as well as gait parameters. So looking at the regularity of the gait as well as balance during walking. However, interestingly, most of our results were beneficial at the later time point. So functionally, we have improvements in weight gain, earlier bladder recovery, as well as improvements in trunk balance. And then in terms of our histological results or results in the tissue, we did see improved tissue preservation, so both in the white matter as well as the gray matter, and reduction in cavity size. So we can see that visually. Sorry, it just froze. Yeah.
Sometimes
That's too far.
okay, good. Can use the. What is it?
Sorry, technical difficulties. Okay, so we observe that visually here. So you can see that in the NX or treatment condition, there is a smaller cavity size compared to the corresponding vehicle. And then we also looked at other cell populations. And so primarily for my project, we observed that there was enhanced neuronal preservation and survival with the administration of the NX peptide. So we can see that visually here. So on the far left, we have NUN, which looks at neurosomal counts. So we can see that being upregulated in the NX treatment group. We also see higher beta-3 tubulin expression, so neuron-specific microtubule expression, as well as higher number of synapses. And so this is just a brief summary. So we saw some improvements functionally at the 4-hour time point. However, most of our benefits were observed at the delayed injection time point. And so overall, NX protects white and gray matter, reduces cavity size, enhances functional recovery and neuronal survival primarily after the 8-hour initial injection time point. And therefore, NX appears to create a neuroprotective environment that is conducive to neural repair and recovery. And overall, this is at a translationally beneficial time window because 8 hours in the rat model corresponds to about 24 hours in humans. So being able to administer a drug therapy within the first 24 hours post-injury provides a good window to be able to administer that in an acute SCI population. And also the animals were overall fairly healthy, enhanced weight gain, bladder recovery, along with improvements in motor function. And so therefore NX shows promise to be administered as a therapeutic in acute SCI. And so our next steps include defining furthermore the mechanism of action of the NX peptide with regards to traumatic spinal cord injury. And so I'd like to thank my supervisor, Dr. Billings, as well as the other lab members, as well as our collaborators at Exeltis Pharma. Thank you.
Right, well done, very good, excellent. Excellent presentation. Do we have any questions? Marguerite?
That's a very interesting subject. Why did you choose female rats?
Yeah, so we use specifically female rats as with the manual bladder expression that has to occur following like spinal cord injury. There's a higher incidence of like urinary tract infections when we use the like male rat model.
Thank you. Albert? Question?
I'm just wondering in terms of your thoughts on why 8 hours are effective to 4 hours in this. I guess the other challenge that we have is SDI patients, particularly I think we're often other sort of comorbidities related to things like that. Is there any thoughts of how type of response may occur and usually a different model that patients may do again to be older or have other sort of medical factors?
So with regards to the 8-hour time point, I guess the first part of your question, so that is something that we are still going to be looking at. So I think our next steps are to look at the mechanism of action of this drug, and so hopefully that will elucidate for us why it's showing more benefit at that delayed time point. So right now we're still trying to discern that mechanism. As for with regards to additional comorbidities that patients may experience in a clinical setting, I think there isn't work right now with regards to testing. We've only looked at this specifically in isolated, I guess, with regards to the cervical traumatic spinal cord injury model that we have, but that could be an interesting future direction to look at how the NX peptide is able to provide that benefit while also considering those comorbidities.
Great presentation. Thank you so much. Okay, our next presenter is Nadine Tan. Nadine Tan,
Well, Nadine is gonna play a video.
just going to play a video.
Yeah.
Hi,
I'm gonna stop
I'm
sharing.
just attending from Boston online. Can you hear me okay?
Yes, we can. Can you speak up a little bit?
Yep. Can you hear me now?
Yeah.
Yep, all good?
Yeah, all good.
Okay.
Make
Great.
sure to check the sound on your sharing.
Okay, sounds good. Could you let me know if you could see my screen up there?
Yeah, we
Yeah,
see
we
it
can
fine.
see it.
Yep.
Okay, great. Thank you so much. So hi, everyone. Thank you for having me here today. It's an honor to present amongst such brilliant scientists. My presentation is going to be a little different than the ones before me. I'm a medical illustrator and an animator, and I'm a recent graduate of the Biomedical Communications program at U of T. So today I'm here to showcase the product of a collaboration that I had with Dr. Failings to illustrate and animate a portion of his research. This was my master's research project, and it's the result of our 1.5-year-long collaboration. So the title of this animation is Bridging the Gap, and it was used to illustrate the use of engineered neural stem cells to treat the injured spinal cord. This animation was intended to be used in presentations for funding agencies, and thus my strategy was to combine what we know about how to create an effective educational animation with what we know about grant writing. So to give you a sense of what this collaboration looks like, it started off with a phase of research where I learned about Dr. Failings' work, how to educate through animation, and how to acquire grant funding. Then I drafted a script for the animation, which was reviewed by Dr. Failings and his research team and iterated upon. Following this, I created rough sketches of the animation in the form of a storyboard, which is something like a series of comic panels. Dr. Failings also reviewed these, and we iterated upon the storyboard for several months. After this, I created an animatic or an animation in 2D drawing form, which is essentially the fleshed out storyboard to describe what the final animation will look like. Lastly, I animated it using multiple 3D and 2D editing softwares. So without further ado, I'll just share the animation with you. Sorry, just one moment. Okay. Can you see this all okay?
Yes.
Yep.
Okay, please let me know if you can't hear it.
Traumatic spinal cord injury begins with a single devastating event, but its effects echo through a person's life forever. To date, over 500,000 people in North America are living with the long-term effects of a spinal cord injury. Some long-term symptoms of these injuries include full body paralysis, breathing difficulties, chronic pain, and incontinence. Why do these symptoms persist? And is there hope that we can change this outcome? After a traumatic injury, damage begins to build up in the spinal cord. The spread of this damage can be mitigated by treatments such as surgery and rehabilitation. However, in many cases, cell death continues for months after injury, eventually forming a cavity in the spinal cord. This cavity, known as the cystic cavity, is a hole in the spinal cord filled with cerebrospinal fluid and inflammatory molecules. Around this cavity forms a dense scar called the perilesional scar. Together, the cystic cavity and perilesional scar prevent the formation of new connections between the brain and extremities and present a major barrier to regeneration. In recent years, neural stem cells have been proposed as a solution to this problem. Neural stem cells are cells that have the capacity to self-renew and give rise to the main cell types of the nervous system. Neurons are responsible for transmitting electrical impulses throughout the body. Glial cells play a supportive role. Some produce myelin to insulate the neurons, while others help to clean up debris. The hope is that when transplanted, neural stem cells will differentiate and replace the cells lost to injury. However, when neural stem cells are transplanted into the site of injury, two major barriers stand in their way. The first is the physical barrier of the perilesional scar. This dense network of fibers and cells prevents many of the stem cells from integrating into the site of injury. The second is the toxic injury environment, which pushes the cells to become glial cells instead of neurons. Without neurons to transmit electrical signals and form the bridge across the gap, these glial cells add little to the repair of the injured area. The Failings Lab has addressed these concerns with a unique and promising solution involving engineered neural stem cells. To address the first barrier of the perilesional scar, a subset of stem cells is engineered to express a scar-busting enzyme called chondroitinase. Chondroitinase breaks down the main fibers of the perilesional scar. To address the second barrier of the toxic injury environment, another subset of stem cells is engineered to express a growth factor called GDNF. This growth factor pushes the cells towards becoming neurons rather than glial cells. When these cells are injected near the perilesional scar, they encourage the growth of new neurons. As the neurons mature and grow in number, they replenish the injured area. The hope is that coupled with targeted rehabilitation, these new neurons will form connections with existing circuitry and allow functional recovery of the spinal cord. Engineered neural stem cells are a promising solution to spinal cord injury. With this therapy, people with spinal cord injuries can expect to have less pain, improved respiratory function, better bowel and urinary control, improved sensation, and restoration of limb function. While this therapy is within our grasp, further funding is required to validate the safety and reproducibility of these stem cells for clinical trials. Together, we can harness the powers of regenerative medicine to create a brighter future for people living with spinal cord injuries.
Thanks, everyone.
Wow,
Dr. Bailey?
that's fantastic.
Oh, thank you.
Wow. I'm writing a grant soon, so I'm gonna be calling you pretty soon. How about?
Okay, that's great.
That's my question.
Nadine, it's Dr. Bailey. Can you hear me? That was
I can
wonderful.
hear you.
It was great seeing the final video, so thank you so much.
Thanks, Dr. Billings.
I just wanted to kind of make the team in the room aware that the University of Toronto has one of the best programs in biomedical communications in the world. And you know, Nadine, this was her master's project, and faculty that are interested in becoming involved, you know, if you let me know, I can point you in the right direction. And the students are fantastic, and they, you know, will work with you. And if you have kind of an idea in terms of, you know, trying to develop something, and you know, I think a video is you know, can be very effective in terms of delivering the communication. So I think that's kind of the messaging that might come out, just to alert everybody around this. So it involves kind of supervising the student. It's a graduate student project, and you need to kind of be involved and collaborate and commit some of your time, but you can see that the rewards are there. So congratulations, Nadine. I look forward to receiving the final product.
Sounds good. Thanks, Dr. Failings.
Any questions on that?
Yeah.
No.
I have a question for Dr. Paling. So what's your take on the Neuralink and how this is obviously your main competitor here in the scope of regenerative medicine, and do you see it competing with the stem cell research?
Well, I think I think that ultimately the different strategies for spinal cord injury will become complementary. And I don't think that they're competitive. I think one of our challenges is trying to figure out how to personalize, you know, the approaches. So I think that so for example, we recognize that the stem cells alone aren't effective. We need to have something to degrade the scar. And then also, we need to actually have active targeted rehabilitation. That's a critically important part. So, and I think ultimately, I think strategies will be complementary.
Great. Any other questions for Nadine? Nadine, what's, just give us an idea of what, I mean, I know you're doing this as a research project at U of T, but if you're in the private sector and asking for someone to put something like this together, what kind of costs are we looking at?
That's a great question. You know, I think that I think it really depends. Oftentimes you'd be working with a company that would determine the costs for you. I'm honestly not too sure what an animation of this length would cost. Um, yeah, I'm sorry. I'm
Okay,
not sure if
that's
I can
great.
answer that right now.
Okay, great. But anyway, great work. Fantastic. Thank you so
Thank you
much.
very much. Yeah, if you have any other questions, feel free to message me. Dr. Failing, if it's okay, uh, they can message me through you.
Yeah, no problem. Okay. If
Great.
anyone has any questions for Nadine or has some interest in doing something for their research grant, we can connect you. Now we'll take a 10-minute break for our main course.
Great. Thank you.
Thank you, Nadine.
Bye.
Yeah, so they're going to the faculty. Yeah. They have a primary advisor. Get their. Yeah, it's going for a big grade or, you know, you trying to, and I want to try to. They have a professional. They have like a grad, maybe that piece. Oh my goodness. Always an inflection point, and then, we don't like, it seems like yesterday was later than they tell. It's like, it just always goes so quickly now. You are.
Are they already? They've done planning?
They eventually come on the citywide television. That's awesome, you know. Particularly, one year.
Okay, everybody, will we continue on with the program? How did everybody enjoy their main course? Great. Okay, our next presenter is Aditya Raj. And Aditya Raj, he will be presenting his research on a prospective observational multi-center study assessing functional improvements after multi-level fusion for adult spinal deformity, 5-year follow-up results. There you go. Take it away.
Where is it?
It's called PEATS. PEATS.
You can do it from the,
It gets
huh?
It gets stuck when it's a
Really? Oh. And then, which one is this? Sorry. Just to wake you up. Just in case.
This is working?
Yeah, should.
Okay. Good evening, everyone. Thank you, Dr. Felix, Dr. E, Nadia, and all the organizing team for this opportunity. I'm going to be talking about this project that involves a prospective observational multicentric study assessing key functional outcomes after multi-level fusion in patients of adult spinal deformity. And this involves 5-year follow-up results. I was working on this project, Dr. Lewis and Dr. Nielsen, so thank them for the opportunity as well. This study was funded through grants by the AO Foundation. So when we look at patients who are undergoing surgery for adult spine deformity, their key expectations are improvement in pain, improvement in function and disability. And we've got multiple health-related quality of life measures that we can use to assess their functional status and disability, both before and after the surgery. However, when we look at these components of the scores in detail, some of these may not be as pertinent for the elderly populations, which form the major share of patients who undergo surgeries for adult spine deformity. And the major concerns for these group of patients remain improvement in pain, walking and performing everyday activities. So when these patients turn up to our clinic and ask basic simple questions, what are the chances that I'm going to be walking, I'm going to be sitting, and I'm going to be doing my daily activities? All we have is that you will have improvement in your SRS scores, you will have improvement in your ODI, you will have improvement in EQ5Ds, which means absolutely nothing to patients. The key question remains, have we improved their standing and walking? Have we improved their sitting? Have we improved their function? So the primary aim of this study was to assess key functional outcomes in these patients undergoing multi-level spinal fusion. And the secondary aim was to see if these improvements are maintained over the follow-up. So this was an international multicentric prospective study over 13 centers of patients more than 60 years of age undergoing 5 or more fusion levels. The indications and choice of procedure was at the discretion of the treating surgeon. And a total of 219 patients were enrolled in the study. The NRS, ODI, SRS scores and EQ5D were then assessed preoperatively 10 weeks, 1 year, 2 years, and 5 years post-op. I won't go into the details of the recruitment, but we basically included any patients who had had previous spinal fusion. We only had 1 or 2 level decompressions that weren't in the inclusion criteria. Patients with other neurodegenerative diseases, paralysis, active malignancies, etc., were also excluded. And we started with about 219 patients at the beginning, and then with some attrition, the 5-year follow-up was about 118 patients. We took components of scores. For the SRS-22 function subscores, we looked at the level of activity, work, doing things around the house, financial difficulties, going out with friends, and similarly in ODI, personal care, walking, sitting, standing, and social life. The mean age of the patients was about 67, and 80% of the group was comprised by females. 132 patients out of this entire group was the retired group, which was as expected. When we look at the function subscores from preoperative to 2 years post-op, we see all of these components show significant improvement at 2 years post-op. And then the improvements are maintained at 5 years post-op. Similarly, the mean scores at 24 months, 60 months, and the changes is not significant. When we look at the overall improvement in each of these function subscores, we see that there's a slight decline in the immediate post-op period at 10 weeks, after which we start to see steady improvement that keeps getting, that stays and then that is maintained over the 5-year follow-up. This is an interesting chart. It's called a stacked bar analysis for somebody who does not understand statistics like me. So the colors indicate the green is, of course, towards a positive outcome, red and orange towards a less favorable outcome. So we see from pre-op, the ratio of red and orange keeps decreasing, and the ratio of green, light green, and yellow keeps increasing in serial follow-ups period. In level of activities, level of work, doing things around the house, and financial difficulties in going out with friends and family. Similar improvements in ODI scores, personal care, walking, sitting, standing, and social life. Interestingly, we see that preoperatively, more than half of the patients were not able to walk 100 yards, which reduced to about 22% at 2 years and 26% at 5 years. And similarly, only 26% could walk more than a mile before surgery, which improved to 63% at 2 years and 57% at 5 years. Similar improvements in standing and other ODI modalities we measured. And this is another stack bar diagram for the ODI showing gradual improvements at 24 months and maintained at 60 months. And this is one of the components of the EQ5D for the pain scores. About 45% patients had extreme pain or discomfort preoperatively, which reduced to about 7% at 2 years, remained at about 7% to 5 years. Looking at the adverse events, of the 219 patients, there were 132 adverse events over the 5-year follow-up period. And the most common was implant failure, followed by junctional pathologies, dural tear, and excessive bleeding. So we found out that all these patients did have significant benefits in specific functions undergoing adult spinal deformity surgeries. 45% patients were bed-bound or had no activities pre-op, which reduced to 18% at 2 years. 11% had no restrictions in standing, which improved to 46%. 20% had normal social baseline function, which improved to about 57.5%. Some key limitations of this study were we did not standardize treatment among surgeons, so this was a heterogeneous treatment group. Adverse effects and revision surgeries may influence outcomes. We saw that there was a significant attrition rate in the patients from 2 years to 5-year follow-up, but when we looked closely, we found that the baseline characteristics of the patients remained compatible to those to the initial population. So to just summarize a few, about 63% of patients at 2 years post-op can expect to walk a mile or more, about 70% to stand more than 30 minutes, and 95% could sit for more than an hour. And 51% patients, so almost half, felt that they function at least 75% or better of them. And similar, 58% were able to walk more than a mile, 68% could stand more than 30 minutes, and 90% could sit for an hour or more. Thank you.
Great. Thank you so much. Question, comment, feelings?
Firstly, congratulations. This is a large number of patients with quite long-term follow-up. I think showing important improvements. Having said that, there was a significant loss to follow-up, which always raises the concern, why are patients lost to follow-up? I noticed that 49 patients, which is almost half the number that you sought final follow-up, withdrew their consent. Did you run a sensitivity analysis to see whether there were any differences in how those patients were doing versus the patients that you followed?
Yeah. Great question. Attrition, was there a bias there?
Thank you, Dr. Feelings. That's a great question. We did look at the patients who withdrew their consent at the final follow-ups, and we found out the baseline characteristics of how it did was exactly the same. Even the rates of complications in both the patients was same.
What about their trajectory of recovery? How were they doing?
Till the time of the last follow-up, they followed the entire cohort.
I see. So you felt that they were represented.
Yes, and even the final population was still represented.
Great. Any other questions? Dr. Yee?
That's terrific, and well, thanks so much. I think population can certainly be very challenging, and as you sort of highlighted, quite salient in terms of the baseline status. I guess the other sort of potential predictors in terms of outcome, and so obviously different surgeons, different techniques. So MIS versus more open procedures, severity, duration of surgery. Are there other variables that sort of shown through the data that you have today?
We do have it stratified for the severity of the cases, depending on the number of levels fused. But we don't have a stratified analysis of whether the outcomes were different if the approach was a front and back or back only with osteotomies, without osteotomies. So we don't have a stratified analysis because the number of patients in each group will turn out to be really low if we stratify to that.
Great. Any other questions? I have a question. Given that your primary outcome is walking ability, what about, given the fact that you're given questionnaires, what about things like objective measures like accelerometers? Any thought about perhaps down the road using something more objective rather than questionnaires?
Sure. Thank you. That's a great question. I mean, that's something we can plan for the future, but to standardize that form of assessment all across 13 centers and to follow the same protocol might be a tedious and challenging job. But yes, that's a great thing we can do.
Yeah. But the good news, the ODI walking score has a high association with objective walking measures, which is a good thing to measure that as well. Great, thank you so much. Terrific presentation. Our next speaker is Daniel Balharis, and he is going to be speaking on his research project entitled Stereotactic Body Radiotherapy for Sacral Metastasis. Deviation from recommended target volume delineation increases the risk of local failure. Daniel, take it over.
Thank you so much for the introduction. Oh, it's here. I just saw it. Thank you.
Let me just share. Sorry, I don't know why this is doing. What is the hope was not. What is the Zoom? No, it was a Zoom. Yeah, what is this? Let's see. Somebody. You got it? Oh, I'm on it. I can see it. Okay.
You can see it?
Yeah.
It's
You can see
still, the
it?
sharing is still on.
Oh, yeah, it's on. Okay, so good evening, everybody. Thank you for having me here. So my name is Daniel. I am one of the fellows, the Radiation Oncology Fellows at Sunnybrook. And it's my pleasure on behalf of my co-authors to talk about sacral SBRT. I have no conflicts of interest to declare. So sacrum is unique as compared to the mobile spine, and to address these unique characteristics, international contouring consensus guideline specific for sacral metastasis was published to guide target volume delineation. According to this guideline recommends an anatomic compartment approach in which the entire involved compartment and adjacent sectors at risk of subclinical tumor spread should be encompassed into the clinical target volume. So essentially, if I have a tumor located in here, I should not treat only the tumor that I see, but I need to have a more comprehensive approach and include the adjacent bone at risk of subclinical tumor spread. The point is that the guidelines rely on expert-based recommendations, and as only 5% of spinal metastases are located in the sacrum, there's limited studies reporting outcomes specific to sacral SBRT, and therefore there are currently no clinical data to support its adoption in clinical practice. Therefore, our study aims to provide outcomes in the largest series to date specific to sacral SBRT, with a detailed analysis on the implication of contouring deviation on the risk of local failure, intending to validate the international consensus guidelines. We've included all consecutive patients who underwent sacral SBRT from 2010 to 2021 from a prospectively maintained institutional database. The primary endpoint was to assess MR-based local failure, including stratification by adherence to target volume recommendations, and the secondary endpoint, vertebral compression fracture. For the primary endpoint, the clinical target volume was manually reviewed and compared to the international guidelines. Sacral segments that did not include the minimum recommended CTV were categorized as non-adherent or under-contoured, with under-contouring further stratified into incomplete coverage of involved compartment as exemplified on the left, omission of adjacent and involved compartment, or both incomplete coverage and omission of adjacent compartments. We included 215 sacral segments in 112 patients. 1/3 of patients had metastasis of radio-resistant histology, and 51% had extraosseous extension. 16% of segments were under-contoured per consensus guidelines, with the main cause of under-contouring being incomplete coverage of involved sector. This is the most important slide of my presentation. Essentially, on multivariable analysis, we've identified that under-contouring per consensus guidelines, radio-resistant histology, and extraosseous extension were all independent predictors of increased risk of local failure. On the left, we see that those segments under-contoured per guidelines had a 40% risk of local failure versus 19% for those contoured per guidelines. When we stratify local failure per number of risk factors identified on MVA, we see that the local failure risk at 1 year was 7% for those with no risk factors, 15% for one risk factor, 34% for those with 2 risk factors, and 57% for those with all 3 risk factors for local failure. The vertebral compression fracture rate at 2 years was 12%, and female sex was the only predictor for increased risk of local failure. In conclusion, this is the largest series to date specific to sacral SBRT. Sacro SBRT demonstrates high efficacy rates and a favorable risk profile. Adherence to consensus guidelines for target volume delineation is strongly recommended as it significantly reduces the risk of local failure and metastasis of radio-resistant stallage and extraosseous extension are at increased risk of local failure and warrant more aggressive local therapies such as those escalated SBRT. I'd like to thank my supervisors and my co-authors. Thank you.
Good. Thank God. Okay. Questions for Daniel? I have a question. What about the uptake of this in terms of what's happening in practice, in terms of, are they following guidelines? Are they not following guidelines? And if not, what needs to be done to get the guidelines to be followed?
That's a good question. So the guideline was published only 2020. So that's why lots of publications before were not following these recommendations, but we expect with the publication to enforce that it is important to follow the compartment approach recommendations.
Okay, great. Thank you, Thank you, Daniel. We have a question here, Michael. Yeah. Give you the microphone so everybody can hear your question.
Okay, so I have a question about the vertebral compression fractures. So it sounds like you stated that it's something like 15%, so it's about what it is in the rest of the spine. And then did you, or I guess it's a little bit less, did you look at how it's varied with, I guess, following or not following the guidelines? Like I was a little bit confused by this slide, I guess, or maybe it's that you don't have enough numbers to do that.
So that's a good question. Indeed, for vertebral compression fracture, we did not put following guidelines as a variable on univariate analysis. We looked at other predictors, and all the others were not significant, like, for example, age or the number of the volume of the metastasis, for example. But this would be a good suggestion.
You looked at any other toxicities?
Oh, yes, that's important. I have it here. We looked at the chance of neurotoxicity. We saw that 6% of patients developed peripheral neurotoxicity after a median time of 18 months. This is slightly higher than compared to the mobile spine, and probably because of the very complex anatomy of the nerves, very close to the treated area. The nerves are very close to the bone, so and the length of the nerve is much bigger than for the mobile spine. So these are maybe some causes why we see a little bit higher toxicity in the sacrum compared to the mobile spine.
Great, thank you so much. Great presentation, Daniel. Okay, our next speaker is Arman Malhotra. And his research is on development of a patient-centered cervical myelopathy severity index, measurement, property testing, item generation, and item reduction. Arman?
Thank you very much. I emailed it back. Perfect. Thanks very much. My name is Arman. I'm a fourth-year neurosurgery resident in Toronto and currently doing my PhD with Dr. Wilson. So excited to present work titled Development of a Patient-Centered Cervical Myelopathy Severity Index. And again, there's a really large team of people that made this work possible. So at the outset, really appreciate the entire team effort. So we know degenerative cervical myelopathy presents with a wide spectrum of dynamic and highly variable symptoms. The importance of accurate monitoring for patients with myelopathy has become increasingly recognized, and particularly for patients with mild spectrum DCM. Existing indices are limited by arbitrary response item hierarchy, imbalanced weighting, and inadequate sensitivity to clinical change. Further, every index we have to date lacks patient input in the design of those indices. So the gold standard being the MJ08. So at the outset, the objective of this study was to develop and test the measurement properties of a patient-reported outcome measure, the cervical myelopathy severity index, using a patient-centered, clinician-informed mixed methods approach. So we adopted international classification of functioning, disability, and health component conceptual framework for this project. And what that suggests is to break down disease entity into symptoms that relate to activity limitations. Within the symptom category, we identified sensory, motor, autonomic symptoms, and within the activity limitations from patients, really things came down to upper extremity function and lower extremity function. So we prospectively recruited in our phase 1, 22 patients for semi-structured focus group interviews, and we asked open-ended questions to ascertain these limitations of greatest concern. And together with our team of investigators, we reviewed these transcripts and came up with a 42-item candidate list of items. Patients reviewed this list to ensure accessible language, readability, accessibility. In phase 2, we prospectively recruited 98 patients and 51 spine surgeons. Patients completed review of this item list for importance and severity. So they would rate their own symptoms, and they were on the whole spectrum of DCM, where some were in an observation state, some were in a preoperative state planned for surgery, and some were postoperative. And they performed this assessment 2 weeks apart to allow us to assess reliability. And clinicians completed the list as well and ranked items based on importance. So the way that we took the 42 candidate items and narrowed that down into a list of a final list using a data-driven process was to come up with these rules for item reduction. And so these are the rules that we employed. Some of these, like Spearman correlation and kappa assessments, they really look at the correlation between items. So really, if you have 2 items that are measuring the exact same thing and are highly correlated, then we would go with one that is either more important to clinicians, more important to patients, or ideally both. And so we did this iteratively and looked at the distribution of responses. And ultimately, we eliminated this 42 item list down to 14 items. And so this is the cervical myelopathy severity index after item reduction. So these 14 items, not by design, they ended up being quite balanced between upper extremity sensory motor function and lower extremity sensory motor function. There was only one item related to sphincter function, which is a difference from the MJOA in terms of the number of points contributing for that element. And so we've developed a new patient-completed 14-item measure for patients with DCM to assess symptoms and functional limitations. Really, this is only the beginning, so we're excited that we're moving forward with multi-center prospective recruitment and assessment of the validity of this outcome measure, as well as measurement property assessment and comparison to existing indices like the MJOA or the NURIC score for neck pain. Yeah, thanks very much.
Great, thanks so much. Questions? Yeah, you have a question? Yeah.
Just not so much a question, just a comment and just to compliment you and Jeff Wilson on, putting together this outcome measure. It was interesting that I think one of the key limitations of the MGOA is that it lacks a metric to assess pain. And I think, when we were first designing studies in myelopathy, we did not recognize the importance of pain. And so it's important, I think, that you're including that. So that's great. Of course, it'll now be important to test drive this.
Exactly.
To see how this actually performs. So, we'll see.
100%. Yeah. Thank you.
Great. I have a question.
Yeah.
How do you see this index rolling out? Is it for primary care physicians? Is it for secondary care physicians? Is it for research? How do you see this tool being used in the future?
Yeah, great question. So I think in the community, the majority of providers that provide care and ongoing monitoring for patients with degenerative cervical myelopathy is really surgeons. It's a disease state where probably, if you look at the numbers, a lot of these patients are followed for a long time, even if they're under observation with repeat imaging, checking them clinically. So what we hope is that this will facilitate more accurate measurement of changes in mildly affected patients. So certainly at the level of providers following DCM patients, particularly surgeons, but also on the research side, we really hope that this can, there'll have to be future work to develop a minimally clinically important difference on this scale. So that MCID is a really important outcome kind of assessment to be performed. But certainly research and in the clinic, I think that's sort of what we think.
Terrific.
Thanks.
Terrific. Great. Thanks for a great presentation. Okay, our next speaker is Alex Back. And Alex will be presenting his research on independence of bowel and bladder function after complete Asia and acute traumatic spinal cord injury, a longitudinal analysis of a prospective multi-center data in 319 patients. Take it away, Alex.
How do I load up?
You have.
I sent it to.
Okay, so you send it, then it must be here. One of these. First the closers. And one of these. I don't know. You can use the clicker.
Hi, good evening, everyone. My name is Alex. It's an honor to be presenting some of my work with Dr. Failings on patients that recover independence of bowel and bladder function after complete Asia traumatic spinal cord injury. This is a longitudinal analysis of a prospective multi-center data set in 319 patients. So I won't belabor this point, but acute spinal cord injury is kind of described as a primary insult of trauma that damages cells and initiates this complex secondary injury cascade that has been kind of described at length by the basic scientists here earlier today. It's fortunately a rare occurrence with 39 cases per million in North America, and unfortunately this has dire consequences to patients that are afflicted. The most common classification system that's used is the Asia classification, which combines essentially a full neurological exam and is most importantly able to differentiate between a complete and an incomplete injury with the assessments of the most distal part of a testable neurological area, which is the sacral area. Around 30 to 55% is usually quoted in the literature as being complete, and this increases with polytrauma, and the conversion rate of, let's say, an Asia A injury to a B, C, D, or E injury is around 20%. And with complete injury, one of the most distal part of the neurological function that may be injured as well commonly is the sphincter function, so the ability of the body's ability to hold urine or bowel at will. And so to look at the independence or the predictors of independence of bowel and bladder function long term after this complete injury, we looked at this high quality multi-center data set called the NACTIN SCI registry, as well as the STATSCIS clinical trial, from which we were able to extract or identify 319 spinal cord injury patients that had complete Asia A injuries. We then used a statistical method called latent class or root-based trajectory modeling, which essentially treats every individual patient and their longitudinal recovery path into different trajectories, and then tries to fit a certain, almost a line of best fit for common trajectories. And then we did a regression analysis to find predictors of that trajectory. The main outcomes for this was the functional independence measure of the bowel and bladder score at 1 year. So upon conducting the trajectory analysis, we found that when following the preset parameters, that a cubic model with a two trajectory group was the best fitting for both bowel and bladder incontinence independence at 1 year. So as you can see, both follow a pretty similar curve, and with around a quarter of patients achieving full independence of bowel and bladder function at 1 year. We then did a regression model with the outcome being the trajectory, the binary trajectory model, and we put in the covariates of demographic variables such as patient comorbidity, their sex, their age, injury characteristics like the level of injury, the mechanism of injury, as well as their preoperative ASIA component scores. And upon doing this, we found that the preoperative upper extremity motor score was the sole significant predictor for both bladder and bowel independence trajectories. And when we tested this to see what was the actual kind of appropriateness and the accuracy of this predictor, we found that surprisingly, the single item model was able to achieve an area under the curve of above 0.7, so quite like a moderate or fair level of accuracy. So in conclusion, around a quarter people with complete spinal cord injury go on to recover nearly full independence of bowel and bladder function at 1 year, and that these two function recovery follow a similar trajectory pattern, and that class assignment to this recovery trajectory can be strongly predicted by a single item model of their initial preoperative upper extremity motor score. Thank you.
Thank you very much. Good presentation, Alex. Got a question for Alex? No? What if you do find this upper extremity? What do you do if you have preoperative? Can you change that? Does it make an impact on your outcome?
I think that's a great question. I think the findings of this is mainly currently at least to as a way of maybe like managing expectations and counseling patients on potentially the probability or their potential recovery trajectory based on their preoperative upper extremity motor score. But definitely like this needs to be validated, and I think that's the next step would be to validate this with a external data set to make sure that this isn't this something that's like theoretical. Right.
Great. Okay, Alex, thanks very much. Any other questions for Alex? Well, let's give a big round of applause to all our presenters. These were the top line projects and FastFest, so they all did a great job. And thank you again for taking the time to present for us today. I'm going to pass it over to Dr. Failings.
Well, I think it's been a great evening. Not sure that we need to hear a lot of speeches at this stage. So I just want to thank Nadia Jabber for organizing tonight. To all of the trainees and researchers who did a great job of presenting, and to their supervisors, and to all of our supporters. It's been a great evening, and Parliament, thanks for a masterful job in putting together. I think this kind of highlights the significant academic aspects of the spine program as well. And Albert, over to you for final words.
Perfect. Many thanks to Nadia and to Harlan for all their work. Round of applause, please. Really like to thank all our supporters that recently. It's been a fabulous evening. It's a great venue here. Thanks so much to the Stratus and for hospitality, and I really enjoy the venue. So I really enjoy the rest of the evening. I Not sure how the Leafs are doing, but keep the tuned. Gets us hope for the next season. But I guess the Blue Jays are gonna have 2 more games at the Rogers Center, so looking forward. So we look forward to, I guess, upcoming events. We have basically quarterly hockey-based visit professional trips, and so as we went to the hospital, Jeff Wilson and thank you so much for the organizing the fall visits and alongside get afterwards by Steve Lewis, the team later on this fall as well for the Tatter Turnbull November 10th as well. So looking forward to those events. Have a great evening. Yeah. Everyone's been yeah, they're probably gonna keep me up here.
Patients are always asking alternative. No, I think, yeah. We did get a chance to all of the good job. Yes.
Remember the medical. I talked to the guy. Totally.
Oh, I guess so. Yeah. Yeah.
Should I write the intro across? But just say you don't agree with a lot of
Well, I.
level, or what needs to happen to do that? What do we have to go down, see if we should have this, either do that, and we're good.
Yeah, so maybe you help myself and that.
That's perfect. Me, the basket is great. Thank you so much. I just, we're trying to, maybe if I can reach out to other people, the guys may do great. It's like, happy to talk to anyone to help dance.
Yeah, so I would bring that up.
There's got to be them for help at some point. It's something she respects.
I mean, like, you're even fine, I see. Well, every weekend. I need whatever and. It's a lot of stuff. I need to see that.
Yeah.
They have to, yeah.
I really wanted to. Thank you.